The outset, I thank organizers, my friend Dr. Bansi Sahibu, to give me this opportunity and be a part of this prestigious conference. I will be talking on perioperative management of diabetes, a case-based approach. This is a history slide. Diabetes was described by Egyptian physician, ancient Egyptian physician Hesi Ra in 1500 BC, and he mentioned it very perfectly that there is too great emptying of urine. So diabetes and surgery, if we see, there is about 20% of individuals undergoing general surgery have diabetes, and up to 60% have pre-diabetes or undiagnosed diabetes. And surgical stress and counter-regulatory hormone release increases the risk of hyperglycemia as well as mortality, infection, and increased length of stay. And this is what a surgical stress response can do. There will be reduced insulin production, increased catecholamine, glucagon, cortisol, growth hormone, and increased lipolysis, all leading to hyperglycemia. There will be, as a result, mitochondrial injury, endothelial dysfunction, immune dysregulation, and superoxide generation. All will jeopardize the surgical healing and response. For any patient undergoing surgery, having diabetes, identify type of diabetes and what regimen he is on. A1C goal for elective surgeries, patient should be having HbA1c below 8, and the blood glucose goal in the perioperative period should be 100 to 180 within 4 hours of surgery. The first case which I am going to represent, a well-controlled type 2 diabetes on OHA, 58 or made elective hernia repair. He is on metformin, SGLT2 inhibitor, DPP4, HbA1c 6.9 and fasting 120. Pre-operative plan, withhold metformin on the day of surgery. Stop SGLT2 3 to 4 days before surgery. As we know, it can cause dehydration, fluid electrolyte imbalance, and ketosis. Hold other OHAs on the morning of surgery and blood glucose monitoring every 2 to 4 hours. Intraoperatively, hypoglycemia is to be avoided by frequent monitoring and, if required, IV fluids. IV fluid with glucose and electrolyte if fasting is prolonged. And rapid acting insulin if blood glucose rises above 180 and IV dextrose if blood glucose falls below 80. Post-operatively, one has to resume OHS once oral intake is tolerated and monitor blood glucose every 4 hours. Ensure hydration and diet and try to maintain individualized glycemic goal. So a word about oral medication use the day before and on the day of surgery. SGLT2Is are to be stopped few days before and after the surgeries. SUs should be avoided on the day of surgery and during NBM period because they can cause hypoglycemia. Glitazone and metformin are safe to be taken pre and intra-op but should be stopped during NBM period post-operatively. DPP4 inhibitor are the safest drugs and can be continued pre, intra and post-op period. There is little data on the safe use of GLP-1 RS. However, American Society of Anesthesiologists recommend that you should withhold GLP-1 RA on the day of procedure or surgery, or if the patient is on a 7-day injection, the one dose should be missed before the surgery. A second case, uncontrolled type 2 diabetes, patient having OHA plus basal insulin, 64-year-old female who is going to go under elective CABG, and she is on metformin, SU and basal insulin, glargine 30 unit HS. HbA1c 8.2 and fasting 210. Diabetes is uncontrolled, and if it is possible, we would like to drop down the HbA1c and sugars a bit. Preoperatively, withhold OHS on the day of surgery and continue 75 to 80% of the basal insulin night before. Switch to basal bolus regimen. And what is most important, avoid sliding scale or only short-acting regimen. And intensive blood glucose monitoring every 2 hourly while patient is fasting. And these are few of the studies which show that post-operative blood glucose level should be maintained between 140 to 180 for cardiac surgery patients. And again, if blood glucose rises, IV insulin infusion, hourly blood glucose monitoring during CABG, and IV dextrose if blood glucose falls. Post-operatively resume blood basal bolus once the patient is stable. Frequent blood glucose monitoring till patient takes oral intake. Gradual transition to home regimen and reinforce education for the future glycemic control. This is the study which has compared the basal bolus with the sliding scale regimen. And it has shown that basal bolus treatment with glargine once a day plus glulisine before meals improved glycemic control and reduced hospital complications compared with the sliding scale in general surgery patients. So the sliding scale is very much popular with our surgeon friends and in surgical hospitals, but it is to be avoided at any cost. And third case, a type 1 diabetes, 28-year-old female who is undergoing laparoscopic cholecystectomy and she is on insulin pump with CGM. HbA1c 7.5 and fasting 135. And this is a busy chart on the insulin in perioperative period. But the contention is that patient with a normal diet before surgery or with a bowel prepared needs 80% reduction in the dose of basal or premixed on the day before surgery. And on the day of surgery, 80% of the basal or 50% of the premix is required. Preoperative plan for minor and shorter surgery, one has to continue basal insulin at 75 to 80%. For pump, reduce basal infusion to 80% and hold prandial bolus insulin while patient is NPO. Ensure CGM or glucometer monitoring. For longer and surgeries requiring GA, patient should be shifted from pump to subcutaneous or IV insulin therapy with either basal bolus or IV insulin infusion and bolus shots. Intraoperatively, hourly glucose monitoring, correctional insulin if blood glucose more than 180, IV dextrose if blood glucose falls below 80. And postoperatively resume full basal bolus once oral intake resumes, restart pump basal to the usual dose and continuous CGM or every 2 hourly check. Watch for hypo with delayed meals and vomiting. And this is the timeline of perioperative care. When the patient is referred, you have to then before surgery assess what treatment patient is taking and make an individualized plan for the preoperative and intraoperative diabetes management. And when patient returns to the ward, he should be again drawn back to his home therapy. So in a nutshell, preoperatively blood glucose is to be maintained 80 to 180 and one has to make changes in the OHS. Intraoperatively, blood glucose monitoring is very important and blood glucose target is 100 to 180. Postoperatively, if patient is NPO, basal insulin is to be continued and avoid hypo is the goal. And postoperatively, if patient is started on oral food, one has to resume OHS and stable glycemia is the goal. So what are the key take-home messages? Maintain perioperative blood glucose 80 to 120. Stop metformin on the day of surgery and SGLT2 3 to 4 days before. Continue basal insulin 75 to 80% and never stop it in the type 1 diabetes. And monitoring is of essence. Hourly for major surgeries and otherwise 2 to 4 hourly as per requirement. And one has to balance between the hypo and hyper and ensure good fluid electrolyte balance. And remember, if you can provide good glycemic control, it will always lead to better surgical outcome. Thank you for your patient listening.